All right. And ECHO is a collaborative learning community. So when we are in breakouts, we ask that you leave your webcam and microphone on and use the chat for discussion or questions, or if you need assistance with anything, we will have someone monitoring that. All right, and then lastly, please just rename your profile to your name and organization or role. And you can do that by clicking on the 3 little dots above your picture and then click rename. All right, so I'm gonna pass it over to our facilitator today, who is my colleague, Dr. Jen Hall-Landy. And Dr. Hall-Landy leads our early intervention work at our institute. She is a psychologist and researcher with a specialty in early developmental delays. Dr. Hall-Landy is also a faculty of our UMN LEND program and leads the ACT Early project. Her work is committed to increasing access and reducing health disparities. Welcome, Jen. Are you on, Jen? Looks like maybe Jen is not on. Is everyone hearing me okay?
Hi.
Her internet just got kicked off.
Oh, okay. Yep. You know what? This is Rebecca, and I have facilitated in the past, so I'll step up to the plate. Hi, everybody. My name's Rebecca Dosh, and I am one of the training directors at the Institute on Community Integration at the university. And today we have, for Project Scope, a focus on neonatal abstinence syndrome and neonatal opioid withdrawal syndrome. We call that NAS or NOWS, and please do let us know if we use acronyms and we will spell them out for you. So that's a really good use of chat. We are organizing the scope for early intervention childhood providers and their families and families. And so please understand that the audience is meant to be teachers and early interventionists, although everybody's welcome. We're using the ECHO virtual training model, which I'll explain a little bit next slide. ECHO stands for Extension for Community Health Outcomes, and it was actually designed by somebody who was a liver disease specialist, and he saw that patients in rural areas were dying just because of lack of access and information sharing. So he began to invite rural providers to come together and learn and share knowledge and expertise. And so in that same spirit, we're hoping to share information about NAS and NOWS so that early childhood providers can know more about this diagnosis and support children in their lifelong journeys as learners and know the signs of that could potentially be linked to these diagnoses. So really it is about sharing information, and we're all learners and we're all teachers here together today. Okay, next slide. There are 4 principles to the ECHO model. Technology, it seems kind of a moot point these days with COVID-19, but ECHO was once very innovative to get online and to discuss across geography and time was amazing. And so we're continuing to use that technology to reach across the state today. The best practices in the ECHO model are to reduce disparity, as I mentioned, and we'll also have a case study. My son is a little noisy. And so in the case study portion, after Dr. Prekker has presented, we'll have some breakouts, and everybody, again, will share their ideas on how best to support the person described in the case. And then we'll share that data out with you. And we'll also ask for your feedback so that we continue to improve. Next slide. All right, so we're in session 3. And today our guest is Dr. Prekker. And Jen, are you with us right now? No. Okay. Well, Dr. Prekker, I'm going to ask you to introduce yourself because I do not have your bio statement. Thank you so much.
That's just fine. There wasn't really much in there.
Okay. Thanks so much for coming today.
Thanks for having me. So I'm Fran Prekker. I'm a pediatrician at Hennepin Health Systems, and I work as the medical director of our newborn nursery here and on our inpatient service. And I have quite a bit of experience caring for substance exposed newborns and their family, and it's certainly a special interest of mine. I've been at Hennepin Health for about 8 years now. Yeah, so general pediatrician. All right.
I'll open your slides for you, Dr. Prekker, so you can just go and I'll go with you.
Perfect, sounds good. So since I already told you who I am, now I don't have to go through that again for this slide. And I just want to share the caveat that I'm really not an expert in this area, but I do have quite a bit of experience caring for substance exposed newborns and seeing infants who are opioid exposed, and really do enjoy and find it very interesting to care for these infants and families. And also, I want to share that most of the time when I'm talking to sharing information about withdrawal in infants, I'm sharing it in a more medical community. And so trying to adjust this for sort of the early education lens was a little bit challenging. So you guys can give me feedback at the end to see if I hit the mark or if I missed it completely. All right, so so disclaimer, I have nothing to disclose, and then the objectives. So we're going to talk a little bit about some of the terms that we're going to use, identify some of the symptoms that are associated with opioid withdrawal in newborns, some of the hospital-based cares that are helpful in addressing withdrawal in newborns, and then a little bit about some of the short and long-term outcomes associated with opioid exposure in newborns. All right, next slide. All right, so limitations. I think the literature around this topic is fraught with limitations, so I think it's good to be aware of that up front. One of the things that we'll talk about coming up is how we define certain terms and how we diagnose specific things. And that those diagnoses and the use of terms is really inconsistent through the literature, which can make it really hard to understand which populations we're talking about and how we have sort of defined that population. One of the other things that's challenging in this literature is that the opioid that newborns are exposed to or fetuses are exposed to has changed over time. So a lot of the initial literature around opioid withdrawal in newborns came out of the 1960s and 70s, where the exposure agent was often heroin. And we've moved way past that now. And so now we're often talking about kids, children and newborns who are exposed to methadone or buprenorphine or fentanyl. And so the patterns around withdrawal can be different. I think that the last thing that's really important to understand is that some of the studies looking at treatments that are effective for withdrawal in newborns don't control for confounding factors that we know impact the trajectory of newborn withdrawal, which just confuses the whole picture and makes it kind of difficult to understand exactly what is effective in the treatment and support of newborns with withdrawal. All right, next slide. All right, so as I promised, some terms. So opioid exposed newborn, this one I think is pretty self-explanatory. This is talking about prenatal exposure of a fetus to chronic opioids. So if you get one or a couple doses of fentanyl or morphine through labor and delivery, that's not who we're talking about here. We're talking about infants that are chronically exposed to opioids before birth. Neonatal Abstinence Syndrome. So this was a term that was coined in the 1970s with some of the initial research into opioid withdrawal in newborns, and was originally used specifically for opioid withdrawal, usually heroin withdrawal in newborns. This got changed in its use over the past few decades so that it kind of got expanded. And so neonatal abstinence syndrome was kind of a term that was used for withdrawal from any substances that you saw in a newborn. So you could have an infant that people described a neonatal abstinence syndrome after exposure to SSRIs in utero or tobacco. Which made it really nebulous to really define the term, because we started using it in very different ways. So about 5 years ago, we started using the term neonatal opioid withdrawal syndrome just to re-specify what we're talking about. So for neonatal opioid withdrawal syndrome, we're talking specifically about the withdrawal syndrome from opioids, although you can have co-exposures. So you could be having a withdrawal syndrome from your opioid that you were exposed to, but also have been co-exposed with tobacco or benzodiazepines or other substances. All right, next slide. All right, so to get infants who are opioid exposed, we have to have opioid use in pregnant people. And you can see, as the opioid epidemic really picked up steam over the last 2 decades, the number of pregnant people who were using opioids or had opioid use disorder also increased. This data is a little bit old, but the rates of opioid use disorder in pregnant people has continued to increase since the 2014 on this slide. Next slide. I think as we want to conceptualize the population of pregnant people that we're talking about, it's helpful to understand a little bit about what makes this population of pregnant women different than a general pregnant population who is not using opioids in pregnancy. So if you just look at a population level, people who have opioid use in pregnancy are more likely to have comorbid mental health diagnoses, particularly anxiety and depression. They are more likely to have recent use of other substances. Tobacco, incredibly common. Alcohol is also common. And then, THC and other illicit substances are also more common in this population. As a population, they tend to be younger, with lower income and have lower educational completion. They are more often have no insurance or public insurance. They report fair or poor health, and they also have some other perinatal outcomes that are not as good as a population of pregnant people who are not using opioids. So higher rates of stillbirth, preterm birth, and poor fetal growth, and also a few infectious comorbidities. All right, next slide. All right, so as we have the rates of opioid use disorder going up over time, we also have rates of withdrawal from opioids going up over time in newborns. The Minnesota Department of Health tends to use NAS, but in this scenario, it is specific to withdrawal from opioids. And you can see that the Minnesota rate has gone up over the last 15 years, slightly below the national rate, but still going up faster than we'd like it to. And this rate has continued to climb since 2015. The most recent data that we have from Minnesota State is from 2019, which is, I believe, is 10.3 per 1,000 live births. So gone up significantly. Another thing that is important about the data from Minnesota is that we are seeing that the rates vary across counties. And so rural counties are more impacted than metropolitan counties because the incidence is considerably higher in rural counties. Yes, thank you. Thank you for that. I was like, I couldn't remember, it was 10.9 or 10.3, so thank you. All right, next slide. All right, so we go from moms who are using opioids in pregnancy with chronic exposure to the fetus. And just as there are changes to an adult person after chronic opioid exposures, there are changes to the fetus after chronic opioid exposure. Most of the time, their opioid exposure of the fetus is going to stop abruptly with delivery. So as soon as that cord is cut, the baby is no longer being exposed to opioids and now can have a withdrawal syndrome due to that abrupt discontinuation of chronic opioid exposure. Next slide. So as we think about the infant and withdrawal in infants, we know that there are a few things that can make the withdrawal that an infant is going to experience worse, and potentially some things that can make it less severe. That being said, there really is no way to look at a newborn at birth, even if you know lots of things about the mom, and predict exactly what that baby's experience of withdrawal is going to be like. It does not seem to matter what mom's medication dose is for things like methadone or buprenorphine, although we do know that babies who are exposed to methadone in utero tend to have a more severe withdrawal syndrome than babies who are buprenorphine exposed. There are a few genes that are associated with a more severe withdrawal experience. And certainly we know that babies who are exposed to multiple different agents, so opioids and potentially benzodiazepines and some SSRIs and nicotine, tend to have a harder time than infants who are only exposed to one agent. All right, next slide. All right, so as we think about what happens after birth for these infants, after they have the abrupt cessation of exposure to opioids, there are a couple different models that help us understand what is going on with those infants. On the left, this is a model that's based on neurotransmitters. Because of the chronic in utero opioid exposure, there are changes to the infant's neurotransmitters that lead to the symptoms that we see. And you can see which symptoms are associated with which changes in neurotransmitters. On the right here is a different way of thinking about the withdrawal symptoms that infants may have after birth. And this one is thinking about the 4 domains of functioning of a newborn. You know, we like to joke that babies eat, sleep, and go to the bathroom, but they actually have to do some other things as well. So there are some domains of functioning that that every baby should be able to function within, and babies who are experiencing withdrawal can have some difficulties with some of these domains. And I think that considering baby's symptoms within this framework can be really helpful as you're trying to figure out what you can do to alleviate some of the symptoms or help the baby, to think about it within a framework like this. Next slide. But I'm a simple person, and so I like to think about things in the most simple way that I can. And so this tends to be the way that I often will approach an infant and see what am I seeing at the bedside and why, and how do I understand it. So since we know that for a lot of these infants, the cessation of opioids happened at delivery, we can anticipate that withdrawal symptoms are going to escalate over time as the opioids get out of the infant system. So for a lot of babies, you're going to see minimal symptoms in the first about 24 hours of life. But as more of the opioids are leaving the system, you're going to start seeing escalating symptoms of withdrawal somewhere in the 24 to 72 hour mark. Two things. So the symptoms that are most common for infants and withdrawal is going to be changes to the infant's tone. So generally, these kids are going to become quite hypertonic and have tremors. The tremors may be there when the infant is undisturbed, but more likely they're going to be there. If you bug the baby, they're going to start having some tremors. They can be quite fussy and difficult to settle. Just like this poor little baby in the picture. I tried to, this actually didn't come out well with my slides here. The seizures are supposed to be crossed out, not the high-pitched cry. Seizures are incredibly uncommon with newborn opioid withdrawal. So I like to kind of take that off the table because that's a really, really, really uncommon side effect of opioid withdrawal. So these kids can have difficulty with feeding, both because they can have difficulty maintaining a calm, alert state to be able to have a successful feed, and also may have difficulty with the oral motor skills of feeding as a newborn. The excessive weight loss is often associated with the poor feeding, and because the child has high tone and a lot of tremors, they have increased caloric needs. And then under the autonomic instability, you'll often see these infants with lots of yawning and sneezing, and may have some temp instability associated with their withdrawal. All right, next slide, thank you. So we have an infant who we know is opioid exposed, and we think that they're starting to have some symptoms of withdrawal. How do we assess that? Are there tools that we can use to help us follow this over time? And there are lots of them. I would say that the tools used are falling into kind of two camps these days. So I put up the most popular one from each of those camps of approach to newborn withdrawal. So the first is the Finnegan. This was the original assessment tool that was developed in the 1970s by Dr. Finnegan. And you can see that it's kind of a laundry list of all of the symptoms that you can have as a newborn experiencing opioid withdrawal, and they're weighted. And so you will do an assessment for an infant every couple of hours and see what their score is, just to see what kinds of symptoms they're having. And people will end up making treatment decisions based on the score as well. On the right here is sort of the new way of thinking about this. So instead of cataloging all the symptoms that the infant is having, this is a more functional assessment of how is the infant doing? Are they able to do their regular baby things of eat, sleep, and be calmed? So there has been a lot of support in the last couple of years for switching to this functional eat, sleep, and console model, and it's certainly associated with some good short-term outcomes for infants. Next. All right, so we're going to use a tool to assess these babies through the hospitalization and through their withdrawal. I think it's helpful to look at what are our goals and what are we trying to get this infant to. And so this is from an AAP, American Academy of Pediatrics article from a couple of years ago that really, I think, stated the goals of care for an infant experiencing withdrawal quite nicely. We really want them to do pretty normal baby things. We want them to be able to eat and sleep and be able to start developing normal social integration with a caregiver. Next slide. All right, so in the hospital, I like to think about them as, or I like to think about our care for the infant as sort of what can we do for the infant and which domains can we help support for this infant to be able to feed and sleep and have social interactions with a caregiver. And really the first 1, 2, 3, 4 things there are what we would consider first line therapy. So non-pharmacologic care for a withdrawing infant. And that just means that everything we would do for every infant, regardless of whether or not we think that they're going to need medication, this would be the care that we provide to each infant. Next slide. All right, so thinking about the first layer there was environment of care. It actually matters where we care for these infants. And I guess not surprisingly, babies tend to do better with when they are cared for by a dedicated caregiver in their own space. Certainly there's emerging evidence suggesting that babies do considerably better when they room in with their mother during their birth hospitalization and have improved short-term outcomes of less medication use and less time spent in the hospital, and also is associated with increased breastfeeding rates. I think that the hard piece of this is that we have traditionally cared for many of these infants within a NICU environment, and change is really hard, and culture change is really hard. So there is really good data supporting that we should be caring for these infants outside of a NICU environment. But making that happen is challenging within a lot of hospitals. Just so you can see what the environment looks like between rooming in room on a mother-baby unit versus an open bay area in a NICU. Infants who are experiencing withdrawal can be very sensitive to noise and light and can easily get overstimulated. So trying to think about the environment that's going to provide less stimulation for them. Great, next slide. All right, so the next layer is that you want to have a dedicated caregiver for the baby. And oftentimes this is going to be a mother, but can be a father, can be an aunt or a cousin or someone else who wants to be there and be a primary support person for the infant. So thinking that it is often a mother, we try to think about how we can care for that dyad together rather than say, okay, the infant is our patient. What are we going to do to this infant? And sort of not think about mom. We really have to assume that to support the baby, we have to support the mom, and to have a healthy mom, we're going to have to help her and make sure that she has all of the support that she needs, and we're able to coach her to be able to care for this baby and respond to the baby's needs. So making sure that we are putting the baby and the mom together at the center of our care and supporting the mom as well. Next slide. All right, so back to this idea of our domains of functioning. I think if we can identify where the infant is having difficulty within their domains of functioning, we can help to figure out how we can address that. So if an infant is having difficulty with motor and tone control because they're hypertonic and they are shaking, we can help by swaddling that baby and holding them close. And we can actually, for lots of babies, we don't recommend swaddling during feeding, but this is a population of babies that actually does better when they're swaddled to feed because they don't have so much of the motor overflow distracting them from feeding. So in the hospital, this can be a really nice way of identifying where babies are having trouble and some interventions that might help with that. Next slide. Growth and nutrition are also really an important part of care for an infant who's experiencing withdrawal, both within the hospital and out and after they're discharged. We do recommend breastfeeding for a lot of these infants. There are just a few contraindications to supporting breastfeeding in moms, including if they're on a medication that we know may be helpful or harmful for the baby, if a mom has active illicit substance use, or if there are a couple infectious complications that we would recommend not breastfeeding. But for the majority of opioid exposed moms or babies, we are recommending breastfeeding. And breastfeeding in these newborns is associated with improved short-term outcomes. I think that the difficult thing is that breastfeeding is often quite challenging in this population, partly because of the baby who is uncoordinated and feeding a lot and has caloric needs that are oftentimes above what would be typical for a newborn baby. These kiddos are at risk for increased weight loss within the first week of life and slow weight gain afterwards, also because of their increased caloric needs. So even infants who are breastfeeding were often ending up supplementing with some higher calorie formula to get them enough calories to be able to grow. And an infant who is not taking in enough calories to be able to maintain their weight or grow often is very, very cranky, and so their withdrawal symptoms can look worse because we're not meeting their nutritional needs. Right, next slide. All right, so those former slides are a lot of the basics around non-pharmacologic care for a newborn, but recognize that there are going to be a percentage of infants who do need medication to help them through the withdrawal process. Just like we talked about what the goals are for supporting an infant through withdrawal, I think it's important to understand what the goals are of using medication. And I think that there is quite a bit of disagreement around exactly what the threshold is for using medication in babies who are experiencing withdrawal. So we, at this point, don't have a gold standard of this is exactly this scenario or the times in which you should use medication to help an infant through withdrawal. We don't know that medication use in the newborn period is associated with improved outcomes in the infant. We also don't know that medication use in the newborn period is associated with worse outcomes. We just don't know at this point. So a lot of the decision around medication use is made around short-term outcomes. Can I make the symptoms that the infant is having right now better? And yes, you can. And it's a balancing act between making things better in the short term and some of our more challenging medium-term outcomes like length of stay and postnatal medication exposure. So medication use around these infants can be a contentious topic. Next slide. So what we do know is that for opioid withdrawal, opioids should be our first line medication for NOWS. In the past, people have used other kinds of sedatives like phenobarbital as first line, But the data supports that we should, if we're going to be using medication for these infants in the hospital, it should be an opioid that is our first line. And there are pros and cons about the several options that we have on the inpatient side for medication. Morphine is the most commonly used medication, but there actually is some data that would suggest that using methadone or buprenorphine is probably a better choice. Medication use for infants who are experiencing withdrawal is very variable, and you will see institution to institution huge variability. At Hennepin right now, we use it in about 20% of newborns, but there are centers that treat almost every infant with withdrawal with medication. And I think that we just need more data and better information about what is the ideal rate and how we can define the ideal factors that we should be using medication for. When choosing to use medication, it's also important to have some protocols that help you decide the threshold at which you're going to use medication, and also how you're going to wean the medication over time. Generally, infants who are treated for withdrawal with medication in the hospital, they are started on medication, and then that medication is dosed every couple of hours for a prolonged period of time and weaned slowly over a period of days to weeks. Because of that slow weaning process after infants are started on medication, starting a medication is associated with a prolonged length of stay for a lot of kids. And length of stay for many opioid exposed babies, it can average around 3 weeks, especially for infants who are going to be treated with medication during the hospitalization. Next. All right, so by the time that we have gotten to going home from the hospital, I think it's helpful to look to consider the list of, or the factors that puts this population of opioid exposed newborns, puts them or separates them from a population of non-opioid exposed newborns. So even by the time they go home from the hospital, these kids tend to have been in the hospital longer, much higher rate of newborn or NICU admission. They are much more likely to have been separated from their mother at some point during the birth hospitalization, higher risk for having had birth complications such as preterm birth. They are much more likely to be small for gestational age or have a small head, which is also associated with lower brain volume. They may have been exposed to multiple substances, not just opioids. The rates of breastfeeding are much lower in this population, and they are more likely to have been involved with child protection or have an out-of-home placement after discharge. So I think as we're considering the long-term outcomes of this population of kiddos, helpful to also look at some of the comorbidities and some of the things that are also associated with opioid exposure even in the short term. Next slide. All right, so I'm a hospitalist, so I think about things as in the hospital mostly. And so it's important for me and for everyone else to realize that withdrawal does not stop at hospital discharge. My goal is often to get kids home in a safe manner when they're doing well so that they can go and be out of the hospital. But the babies are still generally experiencing withdrawal by the time that they go home. Withdrawal in newborns from opioids is often a sort of acute, quite intense period of a week or two, followed by this waxing and waning subacute symptoms of withdrawal for weeks to months. And so I often think about it as a mountain and a lot of foothills. So the hospitalization, we may have gotten up and over the mountain, but there are a lot of bumps to come. And these waxing and waning signs of withdrawal in the newborn can look like sleep disturbances, difficulty with sleep-wake cycle, hyperirritability, or changes in feeding pattern. So these can be very unsettled newborns for a prolonged period of time. This is a graph from a review paper from the journal Pediatrics from a couple of years ago that sort of said the duration of withdrawal for these substances, and it really just says a long time. I mean, who knows how long these go on, certainly more than 28 to 30 days, and they can wax and wane for months. Right, next slide. So thinking about the longer term outcomes, this is difficult to pin down as well. And a lot of the difficulty around understanding the long-term outcomes associated with opioid exposure in newborns has to do with a lot of the confounding factors and some of the comorbidities that are associated with opioid exposure in utero. It appears that kids who are opioid exposed are at risk for poor growth. And certainly we see that in the hospital and in the newborn period of time. They also appear to have increased risk for some visual problems and strabismus. So they might have more trouble with their eyes. A history of withdrawal in a newborn period can also be a predictor of readmission to the hospital for maltreatment or mental or behavioral complaints. And it appears that children who are opioid exposed in utero do have increased risk for some mental health disorders, as well as things like ADHD. Several studies have shown that in utero opioid exposure is associated with an increased risk of death in childhood. And the studies have identified that there's an increased risk of traumatic death that persists into adolescence. So an increased risk of trauma or maltreatment or some other kind of traumatic death. There are also some studies that have shown an increased risk of sudden infant death syndrome in opioid exposed newborns, although that has been variable through studies. The absolute changes to cognitive and motor outcomes based on opioid exposure are also really hard to define. And studies use different testing and different timeframes and different adjustment for confounding variables. But it does seem like prenatal opioid exposure is associated with poorer cognitive and motor outcomes. Just like we were thinking about with the short term at the end of the hospitalization outcomes or factors that put these kids apart from their non-opioid exposed cohort or the other children who are non-opioid exposed. I think it's helpful to think that to remember the things that we talked about at the very beginning of the things that set these moms apart from some of the from non-opioid using moms during pregnancy, and understand that some of the things that we are talking about, like educational attainment of the mother, exposure to poverty, early exposure to substance use disorder, may also impact the outcomes that opioid exposed newborns may have. But there's a lot that we need to understand better about this. but I think that what I want the bottom line for everybody to be is that this is a really high risk population of children who are at risk for poor outcomes for a number of reasons, not just their opioid exposure. Right, next. All right, that's it. What questions do people have?
Thank you, Fran. Thank you, Dr. Prekker. There is one question in chat from Kat Taminga. She wondered if the component of reporting comfort level, if there's a reporting comfort level differences between the rural and urban areas. With alcohol, it can be a factor in rural and urban reporting of whether they're drinking alcohol. And she wondered if this could also be a factor with opioids.
That is a great question, and I can't explain that. I think that the data seems pretty consistent nationwide that that the incidence of opioid use disorder in rural areas seems higher, so they are more impacted than metropolitan areas. If you look at Minnesota, we in the 7-county metro area, we have more infants who are experiencing withdrawal in a given year, but our rates per 1,000 live births is much lower. And somewhere I can share the Minnesota Department of Health has a really nice breakdown of incidence of NAS or NOWS per 1,000 live births, and it's incredibly interesting to see the counties that are most impacted by this.
Leading to that, are there any demographic differences beyond rural and urban areas?
So back to the beginning, thinking about the differences in women who are using opioids in pregnancy and those who are not. So more likely to live in rural areas, more likely to have public insurance, low income, low educational attainment, tend to be younger, and also have a number of other medical comorbidities.
Okay, thank you, Dr. Prekker.
Yeah.
So that was really informative, and I'm sure our audience could appreciate a lot of the information because some of it debunks the what we hear in mainstream media or just what we would think would be common sense, right? So it's great to hear that babies can be supported through through like medication withdrawal versus complete withdrawal post-birth. So thank you for that. Now I'm going to open it up just briefly. We have about 5 minutes. Does anyone have any questions for Dr. Prekker you wish to unmute or put in chat?
Dr. Prekker, I have one question. This is Elise Holmes from MDH. I'm curious how you typically counsel parents who want to breastfeed but are, on like MAT or still sort of in the process of recovery.
Yeah, and so I'm a pediatrician. I love breastfeeding, especially if it's going to potentially be beneficial for the baby's short and long-term outcomes. So I support lots of women with breastfeeding. There's good data to support, and lots of professional organizations support breastfeeding for moms who are stable on something like methadone or buprenorphine. The amount of opioid that gets into the baby's breast milk is negligible. So it's very safe for those moms to breastfeed. Some of the contraindications to breastfeeding would be if mom does still have an active substance use disorder where she's using illicit substances. Each institution, well, most institutions have a breastfeeding policy that will help to define at what period of time does mom need to be not using other substances before she can breastfeed. The Academy of Breastfeeding Medicine would say about 30 days of sobriety before it's okay to breastfeed. although most of the substances that mom might be using illicitly or not illicitly are not going to be in the breast milk for more than a few days. I think, did I get the whole question?
You did. Thank you so much.
Yeah, so breastfeeding is great. And we try to, for the moms who are stable on something like MAT, we often will try to get them to meet with lactation before they're born, to start thinking about what the process will look like and what support the mom is going to need to be successful with breastfeeding.
Okay, Dr. Prekker, we have one last question for you. What is your, what do you feel are the most important factors to consider when supporting children with NOWS for our early intervention providers audience?
That's a big one. I think that these children, as most children, we have to understand within the context of their family and their kind of community. And so trying to figure out not only what does this child need, but what does this family need or this parent need to be able to support that child outside of sort of the medical or educational system. So trying to figure out ways to support the family as a whole. And then one, because you did mention what's in the popular media. The thing that drives me crazy the most when I see in the popular media is people that talk about babies being born addicted. Children are not born addicted. So these babies are not addicts. They are physically dependent on a medication, but they're not addicted to opioids. So that'd be my little 2 cents.
Thank you. Thank you so much. I appreciate you coming today and sharing your expertise with our audience.
Thank you so much.
Yeah, thanks for your time.
Thanks for having me. Okay, bye-bye.
All right, now, so we will now move to our case study, and I would like to introduce our case study presenter today, who is Elise Holmes. She is the early childhood specialist in the Children and Youth with Special Health Needs section at the Minnesota Department of Health. She leads the Follow Along program. It's a county-based program that supports developmental and social emotional screening in children birth to 3. She also supports MDH activities related to autism, children's mental health, and follow-up for children with newborn screening conditions. She is currently redeployed for the COVID-19 response. So thank you, Elise, for your efforts there. I know my son, whom you can maybe hear in the background, is very happy that water parks are going to be open very shortly. So with that, Elise, thank you for presenting the case today. And just a reminder, everybody, we'll share a case. Then we will go to breakouts, and then we'll discuss some of the recommendations that our group suggest. Okay, take it away, Elise.
All right, so we'll get started. So this week's case study, we're going to be talking about a lot of the things that were discussed by Dr. Prekker. So some of the areas we're going to talk about, we're going to have an opioid exposed newborn. We're going to see the kind of NOWS that we just talked about, some newborn child development, family systems. The child that we're going to be discussing is 1 month of age, so still very newborn. And our setting is we're a Part C referral and we're in the home. We'll go to the next slide. Great. So some background, we have a baby boy who was born in the local hospital and was exposed to opioids. Mother and father are both 19, and this is mom's first child. And it does, one of the kind of major successes here is that there's a really great support system from mom's parents, really large extended family, and they're enthusiastic about supporting parents and baby. And mom has admitted that she struggles with opioid use and is seeking help. And she also reports some difficulty and current symptoms with depression and anxiety. Mom is very open to help, again, so with child's help with the child from family and is interested in ECSE. Baby was born full term, but small for gestational age and struggling with eating and sleeping, which we'll discuss a little bit more. And she's been trying to breastfeed, but having some feeding difficulties, and then sleep has been an issue as well. So some strengths and challenges that we see for this case. Some of the strengths are that mom and dad both really want to do their best, support the family, and then have support from their systems in the family. Mom is really committed and active to working on recovery. We have that extended family that lives in the area, which is great, and grandparents are willing to help with some of those basic needs and are living in their home. And then mom and extended family are both also connected to their faith-based community. Some challenges that we're seeing in this case. So mom is still new to recovery. So trying to kind of figure that out, with baby that's only about a month of age. Mom's mental health has still been difficult. So again, that anxiety and depression that we're seeing currently. Parents are young and it's their first child. So they're still really figuring things out in terms of just being new parents and the experience of having a newborn. A lot of those eating and sleeping challenges that we mentioned, and that baby has been pretty dysregulated and having some sensory issues. So some triggers and concerns that we have, again, related to mom, we have kind of being new to recovery, some of those ongoing mental health issues. And then for parents, it's just that first experience raising a baby, being pretty young, but they are very committed and want to raise their son to the best that they can. And so those are kind of some of the factors with parents. For a baby boy, we know sleep has been poor. So waking up very frequently, that also means that sleep for parents has been very poor. Eating challenges, really struggling with breastfeeding, and then dysregulated, having some of those sensory issues and high-pitched cry, which sounds very familiar to what we were hearing about from Dr. Prekker today. And then the next one. So these are our breakout group questions. And I think Rebecca will probably post these in the chat as well, but you can kind of delete out of that first question there. It asks about transportation needs. So I think that was a little more related to our last case, but the kind of major questions that you can discuss when we break out into these groups will be, what sort of interventions or discussions would you have with this family to prioritize? How would you discuss the first things on the list to talk about? Just because things can be really overwhelming, especially early on. So what are we prioritizing? The next question is, how can a family-centered early intervention process support this mom, family, and their child? And then what other strategies do you have that we could potentially try that'll support parents and baby and family? So we'll break out into those groups. And I think we had mentioned this before too, but one of the cool things about the ECHO model is just that everyone that's on the call is both a learner and a teacher. So we know that anyone in one of these breakout groups has lots of really great information to share. So feel free to share all of the information that you know, because we know you all hold a lot of great knowledge.
Looking at the SPP APR data.
Yeah, there's Kat. She knows way more
Hey,
than
everybody.
me.
Yeah, you can find all the years of so not the most current, but as soon as the current report and all of that goes through the federal oversight, it all gets posted on the website publicly in a different, hopefully a little easier to read format for everyone. And I can put a link in the chat where all of those are found. So I'll do that a second. You got to dig through it to, to find what you're looking for, but it's all publicly available.
It's on DAISY too, right? So I think.
Well, I'll start kind of wrapping up. We don't have too much time left, but just going through what we chatted about in our groups, and you're more than welcome to put any sort of your group notes in the chat, and then I'll kind of open it up as well for people that want to unmute themselves. We started off with, what might be some of the priorities. There's a lot of things going on. How might we sort of narrow things down? And our group was really great in that they said, we'll let the parents lead that conversation. What are their priorities? Which is kind of a way of not answering the question, but I think is also a great approach. So very helpful way to think about it, which is what is the family most concerned about? What does the family want to address? Include the family in discussion to prioritize. Great. So then the next question was really about what if a family-centered early intervention might look like, what sorts of, and then kind of folding into the next question, what sorts of things might be most supportive for family. So there are a lot of different sort of chunks related to both the supports that they have sort of already in place and the different types of challenges that they're facing. So kind of based off of what our group talked about, as well as what I see in here, some of the things that we discussed were around mom's recovery and mom's mental health challenges. And so some of that might mean trying to find some sort of clinical support, whether that's her primary care doctor, that's a school social worker that could maybe take that referral, or a county social worker that they could bring in, including sort of other family in the discussion of how to bring that forward. And so that was one thing that we talked about with mom. And so that was supporting mom. We did bring up in our group Mothers First. And this is, as someone that lives in Ramsey County, this is I know exists in Ramsey County, but would be interested if there's something similar in other counties that I don't personally know about. But it's a really great program that supports moms, prenatal nursing, young children that are in or recently out of, want to get into substance abuse treatment. So highly recommend that one if you're in Ramsey County. And so then we talked about some of those issues for some of those concerns with babies. So feeding, sleeping, and some of the sensory issues. So with those, we talked about WIC. We talked about chatting with family a little bit more informally. So maybe that's grandparents, aunts, uncles, people in their faith community. Because we know that a lot of people, especially in that first month, are going to struggle with feeding and sleep challenges. And some of those obviously are, unique to having a child that was opioid exposed, but also some of those tricks and tips might be helpful in terms of how other parents have handled those challenges. And it helps bring that sameness together in terms of just pushing kind of the differences. So we talked about that. We talked about more support from extended family, trying to balance those feeding and sleeping responsibilities so parents can get a break. And we talked about, teen parenting groups and ECFE. So a lot of that around just being a new parent, whether or not your child's experiencing opioid withdrawal, definitely going to just need some advice about parenting and getting things like developmental milestone books and markers that we can get from a lot of different places we can get those. One of ours is Learn the Science Act Early through our IACs and other places where we can really learn about what developmental milestones we might want to be reaching. A lot of really other great things we saw early: Head Start in here, birth to 3 services, some county nursing or home visits, lactation support. So I'm seeing a lot of really awesome suggestions, and I think just a lot of really, positive support for, seems like parents and family are really wrapping around to make sure that this family succeeds. And so making sure that is as supported as possible so parents feel supported. Anyone else want to unmute and kind of mention anything unique that your group talked about?
I will, just because my group asked me to. But I actually am the parent of a baby born, an opiate exposed newborn, born at Hennepin Health. And so we talked a lot about kind of just making sure that with all of these suggestions and supports that we're giving parents, that we're also being very empathetic to the fact that like ECFE and different things may be very challenging for them because they are barely surviving. When they're talking about eating and sleeping challenges, it is like to the highest max that you could ever, the crying, it's not just a baby who's crying a little bit, it's like 23 hours a day. And so one of the specific again, another thing that we talked about is how addressing those sensory concerns, helping with sensory dysregulation, will then follow into some of those feeding and eating areas. But the specific thing that the team, our group had asked is, when we were in the NICU with our baby, she was placed with us as an out-of-home placement through foster care, and is adopted and is 5 now. But she, one of the angel nurses showed us to do a swaddle bath, because bath can be super duper hard for kiddos who have a lot of difficulties with that motor stuff and the tremors and different things. And so swaddling is amazing, of course, but then if you swaddle the baby in a very, very light swaddle and then in the warm water, and then even just running warm water over their body while they're swaddled, was very, very, it was like magic. And again, that was just something from experience, but that, again, that sensory need can kind of go into a lot of other things. So, and again, just that reality that a baby who's exposed and during these times is, it's rough. So that empathy for those parents.
Thanks for sharing, Sarah. And I completely forgot, I had heard someone at St. Luke's discussing Swaddle Baths recently. And so that's a great resource to bring up. That can be really great. I know we had talked, I forgot, we had talked about that a little bit in our group too, some of those sensory things related to sleep and what's in the bedroom or what's in the room that baby is sleeping in. How can we make things as comfortable as possible? Other groups that wanted to share any sort of unique points that you talked about that we didn't bring up yet? Definitely a lot of support, a lot of listening, not trying to throw too many things at once. It's definitely seem like themes.
I really like the idea of having the large extended family coming together and taking turns doing the skinship and, you know, the holding of the baby to the chest, and then everyone's participating and supporting the child, and they're lucky to have that nice large network for the baby. So I really like that idea that my group had. All right, Elise, shall I continue? All right, well, thank you. Okay, thank you so much, Elise, for presenting the case, and thank you so much to everybody who shared your what you are as a expert and as a learner today. It was really beneficial for me to listen to your stories, and thank you for sharing your expertise. I'm being redundant, but so I'd like to thank everybody for joining us today. And as I said in chat, we will provide a case recommendation of the top 3 that seem to kind of rise to the top, and we'll include some resources that people have given us in the chat as well. Thanks again to Dr. Prekker for coming today to talk about, as a hospitalist, her work with families and mothers and children. And thanks to Elise coming from the state for providing a case presentation for today. Let me just, I'm winging it here, people, so I'm getting my script. Oh yeah, so next slide, sorry. I was wondering, where's my slide? Okay, there you go. All right, so as you know, ECHO provides a component of evaluation. So that means already some of your feedback that you gave us informed how we ran ECHO today. So it is important that if you hope to get a certificate of participation and just the goodness of your heart to give us some feedback, it's really helpful. You'll receive an email and it will ask you to fill out a REDCap survey. And once we have your survey, we'll send out the certificate, usually in about 2 to 3 weeks after this particular session that you finish the feedback. All right, next slide. All right, the next session is session 4, June 8th, and we'll be learning about developmental monitoring, child development and early intervention. And our guest, who will have Wi-Fi that day, hi Jen. So Dr. Jennifer Hall-Landy will join us. She works in early intervention across the state and is the ambassador for Learn the Signs, Act Early for our state. Next slide. All right. So thank you so much, everybody. We have 4 minutes left, so you're welcome to leave, or you can hang out a little bit and ask some more questions. And thanks again, Sarah, for sharing your story. Much appreciated. Okay, so everybody have a great day.